For today's case of the week, I wanted to share two cases with you that illustrate a principle that I was not taught in dental school and frankly did not see until I started practicing here at the lab. I don't know if it's more of an East Coast thing perhaps, but it's the concept of a bite stop. And what we have here is a dentist who prepared a bridge. He prepared a 3-unit bridge, and it includes the second molar, the last tooth in the arch, and we'll take a little closer look at it in a second. And one of the things that I love about what Frank Spear teaches, Frank Spear always says that you cannot get into trouble prepping a single unit crown unless it's a second molar. And that's the one time where if you have interferences there that you don't account for ahead of time, you can prepare the tooth, think that you have enough reduction. I've had this happen using depth cutters where I'll reduce a millimeter and then my assistant will bring the temporary to me and say, look, and there's practically a hole showing through there because now all of a sudden, after we adjusted it, the jaws have come closer together because of that prematurity on that second molar. And so Frank always talks about that. The only single crown that you can really kind of get into trouble with is on the second molar. And so what this doctor has done is left what we call a bite stop. And as we look, I'll spin this over, and you can see the entire tooth is prepared. Again, we have a 3-unit bridge here, except for that one cuss tip that has not been prepared. So that's actually at the original height. So the doctor prepared the margin. All he didn't do was do the occlusal reduction over there. And so he prepared it, had the patient bite down, and took the impression. And what this looks like now, when we close the model, is we have that cuss tip in contact to be able to set the pin for ourselves. And if we look at it from the back and zoom in a little bit, we'll see we have reduction. We certainly have enough reduction for the bridge. You can see if we get that in focus, there you go. There's the bicuspid with enough reduction. There's the molar with enough reduction, but we have contact with that one stop. And the doctor's telling us this is the vertical dimension where I want this to occur and didn't want it to collapse at all. And so we mount the model with that little bite stop on there. And then what we do is simply make, one of two things, but the easiest thing for us to do is to do a reduction coping. And that's usually what we're going to do is knock that off or make a reduction coping and then grind it down so that we've got a reduction coping, or knock it off and then make a reduction coping with or without a hole based on the doctor's preferences. I like ones with a hole, but certainly you could use one without a hole as well. And so the doctor has one of two options. He can either, as soon as he takes this impression and the bite and sends it to us, he can knock this off at that time and then make a temporary that goes over there. And he'll leave that a little more tooth structure than he thinks we're going to need. But even if he goes a little too far, it's not going to matter. As long as when we send him the reduction coping, it fits right onto that tooth, he'll know that he reduced enough before he made the temp. But I've seen some doctors leave that there based on how much tooth structure is there. So there'd be a temporary around the bicuspid, a temporary pontic, and then a temporary all the way around here, except you'd actually have the tooth showing through right there. And you'd polish the temporary back so that you'd have that tooth sticking through the actual temporary itself. And then the doctor would take our reduction coping with the hole in it, set it over the tooth, and then prep that down until it was level with the reduction coping. In fact, I'll often use a football burr just to give myself a little bonus reduction with that type of reduction coping because of the convex shape of the burr. Or, as I said, the dentist could just prep this down right now until it was even, the same thing we're going to do and approximate it. And then when he tries on our reduction coping, he'll know if he reduced exactly the right amount, a little bit more, or not quite enough when he does that. So it's a nice little way on those second molars to make sure that you maintain the vertical that you want to maintain by leaving that there, and we're more than happy to do that. And then another doctor with the same concept. This case got out the door before I had a chance to actually bring it in and show it to you. But this doctor's opening the bite on a full mouth case. And so he's gone in and prepped all the teeth except for one. But you can see the space here between that virgin tooth and what we've done across from it. So he's opening the bite, and he's doing this based on the CEJ measurements, sometimes called the Shimbashi measurement, where you measure from CEJ to CEJ from an upper tooth to a lower tooth. And he's prepped these teeth and put the temporaries in at the patient's existing vertical dimension, opened it a little bit, but then he wants us to open it even more. And so what we've done is open it according to his prescription, and then we've put some little support bars in here. We've soldered on, you can see these pads that we've soldered on, so that when he tries this in the mouth and has the patient bite together, he can check whether or not this vertical dimension is correct before the porcelain's applied to all of these units. And so it's a nice way for him to be able to go in with the metal try-in. And first of all, he's going to take an Explorer and check, obviously, the margins of all these units. Make sure there's no rock and make sure it fits. I like how we've got a separate bridge here. No reason to try to cross the corner and go back there and connect it all if we don't have to. And so he's going to be able to have these pads here, and he can measure from CEJ to CEJ where he took his measurement, which I think was between these two cuspids, and make sure that we've got it the right vertical dimension. Now, if we've opened it too far, and that's what we have a tendency to do intentionally, is to add a couple tenths of a millimeter, he can grind a little bit on these pads and close that bite down a little bit. But if he puts it in and for whatever reason we were short a little bit, I've seen doctors put Duralay in between here. I've seen doctors prep a couple dimples and put some flowable composite to kind of open those pads up again and do that. So on a large case like this isn't a bad idea. Frankly, we don't do a lot of metal try-ins, and considering we have a no-fault remake policy, I think there's nothing wrong with doctors skipping this step entirely. But if you're going to open the bite on a full arch, full mouth case like this isn't a bad idea to be able to go in and try this in and measure the vertical and see if you are where you want to be. If you make adjustments to these pads and close it or add something and open it, then we will remount it to that vertical dimension and then build the ceramics on here and send it back to the doctor. So a couple interesting cases that I wanted to show you of a doctor leaving an occlusal stop on a natural tooth, and then us adding some occlusal stops in metal on a metal try-in. One is aimed at preserving the existing occlusion, and one is aimed at opening the bite and getting an accurate representation of that. We're happy to do either of these with you if these clinical situations ever present themselves in your office.